trying to differentiate empathy versus sympathy. How different are they? Are they completely different? Are they two versions of the same thing? Classically, they're both feelings that are created that we experience when we see others suffering. Sometimes they're viewed along a spectrum between pity and compassion. But I think there's a fair amount of overlap, and they can happen at the same time. They can be both end up in the result of compassion, and it's not necessarily sort of as black and white as that linear path would imply. So trying to define them a little bit better. Sympathy is classically feeling with someone's emotions, not actually feeling the same emotion, but having a close connection with that person, and typically linked to a desire to help them, and possibly, going towards compassion. So the government officials express sympathy for the families of the coal miners who died in the explosion. Nobody's and I'm not trying to imply the sort of government detachment from, we'll throw some money and it'll go away. I think this is, generally, it's pretty much impossible for any person that didn't lose somebody in a mine explosion to experience that same type of feeling. So that's what I'm trying to get at with that. And you'll see these two terms mixed up in the media and in literature fairly often and used incorrectly. Empathy is actually physically sharing the emotions of others, mutual experience of emotion, feeling into someone else's mind. You feel empathy when you've been there or walked a mile in someone else's shoes. One of the good examples I found, or at least entertaining examples I found, was when they were trying to have men have empathy about high heels. And the only way they managed to do that was actually have them walk a mile in high heels. And then they said that those men could be empathetic about the pain of walking in high heels. So, but in the caregiver experience, if you've lost a loved one or lost a child, then you are more likely to be able to empathize with a mother who has lost a child. But some caregivers certainly blur the line as they emotionally put themselves in the patient's shoes, even if they haven't been in the exact same position. And you can, especially if you've been caring for a patient for an extended amount of time, you actually, you begin to love that patient to a certain degree, not necessarily to the same extent as the mother themselves or the parents or family themselves, but there is a emotional connection there. This is another quote just to try and look at empathy. So you can feel sympathy knowing that there are 1 million Chinese starving, but unless you know one Chinese who is starving, then at that point you're feeling empathy for them. This is getting a little more technical. 4 qualities of empathy: to see another world as another person sees it, not judging them or judging the situation, and then understanding another person's feelings. So you actually, again, this is part of where the perspective comes in. You have to be in touch with our own feelings, but be able to put them aside to understand others' feelings. And then communicate our understanding of those feelings back to the person that you're interacting with. So saying, I understand how difficult this must be for you because I went through a similar thing myself, but not necessarily trying to fix the problem or make the problem better. So great, thanks for the vocabulary lesson. I'm sure you're very excited about that. What does this have to do with coping with loss? I think first we have to understand that loss doesn't always mean death of a patient. It can be, and we also have to, we kind of normally assume that when we're talking about coping with loss that it's the patient who has experienced the loss that we're concerned about. But today's focus is how we cope with the loss of a patient's loved one or a patient themselves. And then so loss may take other forms, not necessarily death, maybe a gap between expectations and reality. So oftentimes children I see are born with birth defects, or soon after birth they become ill. and that's a loss for the family, because inevitably they have expectations about what they expected childhood and newborn children to be, and generally it's the shiny, rosy, happy picture, hopefully, of what it was going to be like, and anything less than that can be considered a loss. So, but we are not immune to experiencing that same thing. When we are not expecting a child to have some type of defect, it's definitely traumatizing to the caregiver as well, to some degree. So I asked everybody here to kind of ask yourself, what is your perspective? Acknowledge that you have a unique perspective that may alter your emotional response to events. That hopefully is for better. Hopefully you have a better, broader perspective, having been in the healthcare caregiver field. But there's always a possibility, if someone has just started in the healthcare field and the first 2 or 3 patients they see all have terrible, horrible experiences, you may have a potentially distorted view of what being a caregiver is, and that can negatively affect sort of how you progress through the next 3 or 4 patients. So, and also then acknowledge that the family may have their own unique perspective, and how to basically you have to find the similarities and utilize those towards delivering care, but recognize the differences and try and set yours aside. So again, we talked about the event, plus the perspective results in an emotion, whether the event is a mother losing a child at birth, mother losing a child at 2 weeks from sepsis, mother losing a child after 4 months of constant care in the NICU after surgery for a heart defect, or losing a child after 6 years of having a normal, healthy child. All of these experiences are very different, and are going to sort of require different response. So what happens to the mother? What is her perspective and what is her experience? That's hopefully what you got some idea of yesterday from the stories that you heard. I don't know if anyone talked about the 7 stages of grief, but I'm sure you've probably at least heard about the 5 stages of grief. And this is sort of a modified version, including shock and then testing. But this is what the mother will go through, not necessarily in this neat color-coded order. There are sort of a host of other things which kind of mix in between all of those stages: numbness, confusion, disbelief, sadness, guilt, loneliness, etc. The loss of the ability to sort of self-reflect and figure out where you are in this process, and the inability to gain perspective. So what happens to the caregiver when you're taking care of this patient with the exact same loss? What do you guys think? It's going to look really similar. But I think a lot of caregivers are like, well, I've seen this before, and I don't see myself going through these stages of grief or even necessarily experiencing grief. And I think that's potentially a good thing. But the fact of the matter is you probably are going through these stages. You may just be processing through them faster, and possibly a little bit healthier as far as the processing. But you still need to be aware that it's happening, and possibly that if you're not experiencing any of these stages, that maybe you're not coping well with it at all, and you're just kind of moving on and sweeping it under the rug. So the difference, obviously, is the loss is personal for the mother or the patient, and the mother has never, hopefully, experienced the death of a child before, and or a significant alteration from what their expectation is. Whereas the provider's loss is secondhand. No matter how close you are to the patient, you can never really equate your loss of the patient with what the family is feeling. And likely, depending on where you are in your career, you've experienced some type of loss like this before, although even if it was sympathetically or empathetically, it's still, you've had some experience with it. And that experience will alter your perspective and will alter your expectations. And it may allow you to start the grieving process earlier and progress faster. I think it's important to understand that every once in a while I get surprised at how quickly some families process grief. I've been doing this for 10 years, as I said, and there's still families that end up ahead of me on the grief processing curve, where they're already making decisions about organ donation and or funeral planning for patients that for children that they've lost, and I'm still reeling from the fact that we weren't able to save the child. And I guess one extreme example of this is when I was working in Sudan with Doctors Without Borders. Death is almost kind of a way of life there. They're very in touch with the fact that life is not they don't take it for granted. And so we had patients come in who children would be very sick. We had a mother who had twins, both who had measles, and one of them, after several days of intensive therapy, succumbed to the illness and passed away. And the mother, as soon as we told her and as soon as she recognized that the child had gone, fell on the ground and started wailing and beating herself on the head, and that was very traumatic, and we were kind of in shock at the same time, and this went on for about 20 minutes, and we weren't really sure how to sort of culturally what we were supposed to be doing, but after 20 minutes she picked herself up, dusted herself off, picked up her other child, and left the hospital to go back to her family, which was a two-day walk away. So it was, and she was essentially, she had progressed through her grieving stages, and she would go home and continue grieving with her family. And we were still kind of standing there wondering what had just happened, and weren't able to sort of go through, have our normal cultural thing where we sit down with the family and be with them and have long drawn out conversations and sort of work our way through it along with the family, and so that was definitely one of those eye-opening experiences where we don't all process grief the same way. So there's no vaccination for grieving. Just because you're a provider doesn't mean you're immune to grieving. In fact, a lot of people think that an essential component to being an excellent caregiver is to be vulnerable and to experience that grieving. And coping well does not mean on the same sort of flip side, if you have a tragic loss of a patient, if you process that well and healthy and you're able to move on and continue doing things, that doesn't necessarily mean that it was any less sad or meaningful experience for you. It's just how well you process things. Another question that gets asked is empathy better than sympathy? I would say in a fair amount of the literature, it's promoted as the more powerful of the two words. It is generally considered a deeper connection. Obviously, you're feeling the exact same or some very similar emotion to the patient versus understanding their emotion, but and caring for them compassionately from a slight distance, I guess, is the easiest way to say it. So I think my saying is you have to understand when you're being empathetic, when you're being sympathetic. Empathy, although possibly a deeper connection and possibly more powerful, is also probably more draining. So depending on where you are in your emotional cup, you need to be able to sort of decide whether you can be sympathetic with a patient or empathetic with a patient at that given time. If the empathy is starting to empty your cup to the point where it's affecting your work or life outside of work, you may need to change your approach and or take a break and take time to fill up your cup again. Your job, the quote that I saw multiple times was, "Your job is to help the swimmer, not drown with them." So that is important to remember. It's not, you don't have to overextend your emotion simply to say that you were empathizing with the patient again. So simultaneous coping, being aware of that framework I keep talking about, puts you a step ahead as far as working through the process of grieving, both your own as well as the patient's. You're going to really need to probably try and understand that framework before you're in the care setting, before your patient is experiencing loss, because as the patient loses perspective when they're in grieving, so will you. And it's not necessarily a time to be evaluating what your framework is in that setting. That may just mean you've just lost a patient, or your patient is not doing as well as you would like, and you stop for 2 minutes outside of the patient's room before you go in and talk to the family, and just kind of collect your thoughts and sort of see where you're at, and know where you are. And more than likely the family is going to be in a different place, whether they're ahead of you or behind you. Typically they're going to be processing things a little bit slower. Depending on what stage of grieving they're in, you're going to have to try and identify that and support them based on that stage, and it's a little bit different for each stage. And then compartmentalizing care is, all of these things are not easy to do. I would say compartmentalizing is one of the harder things to do. It's essentially keeping your emotions and your grieving separate from the family. That doesn't mean you have to be cold and removed, but it does mean that when you're in the patient room trying to help them cope with grieving, they shouldn't be wondering who's going to take care of you. And they shouldn't feel the need to take care of you, obviously. So this is a very short slide on coping as far as those stages of grief that I showed earlier. I think one of the most important things, and it's not part of the stage, is preparation. So if you have spoken with the family, regardless of how long you've been working with them, if you've spoken with them about, from the moment they get to the hospital, what the reality of the situation is, what the possibilities are, share your goals as far as the best possible outcome for them, for the patient, but also share with them the worst possible outcome. Is this a potentially fatal diagnosis that they have? And that can be scary, and it's sometimes hard to share those sort of dire prognosis with families, and sometimes we avoid it in an effort to try and make things rosier than they really are. But that will go a long way towards helping them begin the grieving process if things should go not as planned, or if they should progress as you expect they might, if the patient looks very ill up front. So when they first realize that there is a loss, just simply being present, I think, is the most important thing. Trying not to do too much talking. I think at least early in my career, I felt like I had to explain everything and talk about things, and more often than not, they didn't hear the families wouldn't hear anything that I was saying, and nor did they particularly want to hear anything I was saying. So just being with the patient, sitting next to them, is very important. For the denial stage, a lot of that as a provider, again, is just listening, trying to understand where they're coming from, focus on the facts that you have control over. Don't pass your opinion or any judgment. A lot of times this progresses where the families become angry, whether they're angry at the hospital, you as a care provider, at religion, or whether it's directed at science in general, that we haven't come up with a cure for the particular loss. Essentially, key here is don't take it personally, legitimize it. They have a right to be angry. It's not fair what has happened to their family and or child. And then again, we can sort of, don't need to go through each one of these, but part of why I wanted to go through each of these is this is how we help the mothers and the families, but then we ask how to help ourselves through the stages of grief. We do feel these stages of grief in some way, shape, or form, and I think it's important to go back here and look at this. So, have somebody that can be present for you, have somebody that can listen to you, have somebody that won't take it personally when you yell at them, and then try and create this type of environment for the later stages of grieving, where you have structure, where you have support, and will help you if you have those things in place before you're under stress or experiencing loss at work, then that will go a long way. So these are some of my personal experience with experiencing loss and things that seem to help me. Everybody's a little bit different. I think taking your time is very important. You don't have to process everything right away. Some people, we all lead busy lives and we all have full lives, and we feel like we need to get through this grieving and get it over with quickly. You don't have time to be grieving every day or to be depressed or do any of these things, but they're all important parts of getting through it and moving on. So pace yourself. If you're good at compartmentalizing, you can set it aside. You can go back to work the next day if that's going to help you cope. You can take a day off the next day if you need time to yourself. So it's really going to be quite individualized, but don't feel the need to try and cram all of those 7 stages into an hour on your lunch break. It's not going to happen, and it probably won't result in the optimal healing. There will be ups and downs. I tell this to all the families from the second they get to the ICU, that it's a roller coaster. There will be good days, and you have to be careful that you don't get too high on those good days, because there's a good chance that they will be followed by a downside, and trying to plan ahead for ultimately what the long term is. And as long as from day 1 to day 7 your net total is a positive, then that's really what you should be focusing on. Is sort of the stock market mentality, where you can't go on a day-to-day or hour-to-hour basis, or you'll drive yourself crazy. So take your space. This means a lot of different things to a lot of different people. Some people need to be alone in order to process grief. Some people have one other special person that they know they can count on. Some people prefer to grieve as a group, or a quiet room, or whatever your happy place is, whether that's on a mountaintop or I don't know, a casino, or it doesn't matter. As long as you feel comfortable there, that's the most important thing. Talk about it and feel it. I think part of what happened yesterday is people sharing their feelings, and that's part of their grieving process. And being willing to feel those and cry and be angry and do all that. We always talk about sort of suppressing feelings, and that ultimately comes back to haunt us, probably when we least expect it. Acceptance is the goal. You're not trying to forget the patient or necessarily move on or use them as a building block. You're basically just trying to accept that what happened, and make the best of it. And often you can use that acceptance to, one, distract yourself, but also redirect that energy. Ultimately, your loss or your grieving, it's a very powerful feeling. Whether it's extremely angry or extremely sad, it's a powerful emotion, and essentially what it's a reflection of is how much you invested in that patient, how much you love that patient, and if you can redirect that, it's gone from a powerful feeling of love to a powerful low of grieving, and redirect that same energy exactly as a roller coaster does. It can slingshot you back up to the top if used appropriately. So I think that's important to understand. If you're really down in the dumps, that's a lot of potential energy that you can use to move forward. And I think a lot of the people here and a lot of the people that maybe spoke yesterday have taken their grief and used it and shared it with others, and that it goes beyond just sort of building yourself back up, but you can use that power to help motivate others. So fundraisers, foundations, administrative change, activism, support groups, all of those things are very powerful. And I just got back from a conference with the patient safety movement, and we had a very similar, lot of presenters telling their individual stories about preventable medical errors, which is a very real thing. And those were the things, not the statistics of however many thousand preventable errors there are don't mean a whole lot, but when you hear about that one patient that lost their husband or lost their child because of a medical error, it means a lot more. So that's another way, a great way of coping. And then step back and re-examine. Focus on what you have, not what you've lost. As I said earlier, if you're in the midst of anger or denial or depression, it's difficult to have that kind of perspective, but if you can have somebody that can sort of try and give you that perspective when you're in those stages, or certainly start to provide it when you're moving through those and ready to start to move forward towards the next steps, then it can be helpful. And call on your favors. I'm from the East Coast. We do not ask for help. And if the help is offered without us asking, we probably won't take it the first time it's offered. And that's not a particularly good way of going through life. And certainly when you're dealing with loss, it is not the time to be proud. That is the time to ask for help. It's the time to call on your favors, to call on financial, when people owe you money, or even if they don't owe you money, ask for financial help, ask for childcare, family, friends, church, colleagues. Don't wait for it or necessarily expect that people are going to go out of their way to help you. But if you do go out of your way to ask people, you will be surprised how many people will be willing to give it. So in the same way, a lot of times your colleagues may be suffering, grieving, but they do a really good job of hiding it. And so if you think that may be the case, if you offer your help, you may be surprised at how much they accept it, as long as they're not from the East Coast. But and then I think it's also important, these are all sort of positive ways, but you also have to realize that not everybody is going to understand your grieving. That's part of vicarious trauma, is that you have chosen a career where you're seeing a lot of loss at times, and sometimes very difficult to understand, and not necessarily loss that had any good answers or potential solutions. And other people don't choose those careers and do careers where things are very predictable and very controlled, whether it's engineering or mathematics, or there's lots of careers where things are much more under control. And so don't expect that when you share your grieving with whoever you choose, they may not understand, and you're not required to explain it to them, but sometimes in explaining it to them, if they're willing to listen, though they may not understand at first, if they're willing to listen, you will not only get their support, but you may actually get some understanding of what you're going through simply by verbalizing it. That's one of the things, just continuing to talk about it. And be willing to accept the help. I put that there for myself. And then choose your shoulder to cry on wisely. So if you've been through this before, even though you may have chose your partner for life as somebody you love very much, they may not be the person that you go to with grieving about loss at work. There may be another person at work, one of your colleagues, who has been through similar experiences and is more understanding and more able to provide a good support network for you. And I think that's often underestimated. We sort of see our personal life as where we solve our personal struggles, and our work is, we're expected to be strong there, but there is a lot of support at a lot of workplaces, so that's important. So in summary, take care of yourself first so you can care for others. Don't be the hero. I guess the final story I'll tell about that, when I was early in my training, this was hammered home to me. When I was taking EMT class, our EMT instructor told a story about on one of his first calls, he went out with a paramedic, and they found there was a person that was down. It was unclear there was a car accident, and the paramedic, his friend, rushed to help the person. And when he got within like 5 feet of the person, his friend collapsed, and he wasn't sure what had happened. But ultimately, it turned out that there was a power line which had fallen down in the car accident, and the ground had become electrified in that area. And so now, instead of one person to try and revive, there was 2 patients down, and ultimately he had to show the restraint to wait until the power company had turned off the line before they could go and resuscitate either of those patients. And that's obviously a sort of a physical injury, but the same goes for mental health as well. So you have to take care of your mental health first. Take time, understand your perspective, understand what you've been through and how you view things, and how much of an expert are you, or how much of a novice are you at dealing with loss, and are your mechanisms of coping for loss healthy, or are they potentially unhealthy? And so doing that when you're not in the hospital and when you're not immediately experiencing loss will go a long ways towards delivering better care and delivering more enlightened care to your patients. And then be sympathetic and empathetic without losing sight of your role as a caregiver. Everybody copes differently, and respect and understand those differences, and don't be afraid to ask for help and be vulnerable. It's what makes you a great caregiver. That's the end of my talk. So glad to see that we've a few more people have made it in from the traffic. Congratulations. I don't know, I guess how much time I have. I have a couple 10 minutes or so if anyone has any questions.
I work with our communities of obstetricians and pediatricians, all of them, and one of the things I'm trying to do is educate them on how to be more sympathetic, maybe, instead of empathetic, because I think you can't, and I really don't believe you can be empathetic unless you've been through something similar.
Sure.
So sympathy will start with, but what do you recommend as a doctor? Because that's one of the things where, they get so angry. I work in mother baby, so I see a lot of infant death, and they get really angry if parents can't make a decision, for example, on an autopsy or not. So
Sure.
they'll go home and then be called back to write an order, and they're not happy. And I'm thinking, but you went through this woman's pregnancy,
Right.
her. So anyways, I'm just looking for suggestions on how to approach a doctor.
I think, yeah, that's a great question. I think the best way, it's difficult because essentially what you're trying to do is this patient, the doctor has been a certain way for their entire life, and they have a very different perspective. I guess the first thing is try and understand where they're coming from, and it's going to vary from each doctor. Everybody's a little bit different. I'm not surprised to hear that. It makes me sad to hear that that happens, but I see it all the time. Um, I think that trying to give the patient a voice, so you actually talking with the doctor, assuming the culture of your hospital is such that it's appropriate for you to have that discussion with the doctor. That's also part of it. Ultimately, we're trying to create a culture where you are on the same level as your physician, and you can and have that conversation and not feel like you're going to offend them. But unfortunately, sometimes it's hard. So for if those same physicians feel like there's a hierarchy and their word is that's part of the problem, is that they think that when they say you should have an autopsy or you shouldn't have an autopsy, they should just, that's the final word, and nobody else should have an opinion, even though it's the patient's or the child or the mother's child. But I think, as I said with you guys saw yesterday, when you hear those patient stories, trying to bring them back to what the mother or the father or the family has been through, and their understanding of the situation, what their perspective is. It's not easy. There's no easy answer, because mostly you're trying to break through a wall that's been built up over decades. But those personal stories are, I think, what breaks through that wall best, not generalizations and big picture.
I was just going to comment that I do a lot of medical teaching for residents and medical students. I'm a social worker at UCLA Mattel, and I found this great article, and I handed it out to everyone, even the older attendings, and it's called Learning Not to Move Forward. And it's written by a resident who said all of her mentors would teach her after a death or during a death just to move forward, and how unhelpful that was. So now it's literally a page and a half, and I bring it to every debriefing, and I highly recommend it because I don't think it's too late. And I think with the younger ones, it is a terrific article because it's a personal account. It's called Learning Not to Move Forward, or Learning How Not to Move Forward, and I can send it to whoever wants it. Just contact me after. But
Yeah.
It's really, really moving and powerful, and it shows them that that's not a healthy coping mechanism.
Yeah, and I think what you said is also important, that it's never too late. So don't just accept that, even if that physician has had that same response every single time. If you speak to them with sincerity and emotion, and not being mad at them because they're seem like a jerk, you have to look at what's their perspective, why are they this way, and yeah, if you give them the article and they read it, great. If you give it to them and they don't read it, you tried, and maybe next time. I mean, it's the same thing when we have conversations with families about difficult situations. We may have that same conversation 3 or 4 or 5 times, using the exact same words, sometimes trying to change it up, and sometimes even if you said the exact same thing, the 5th time they hear it, and it means something to them, and they are able to, it helps them. So I think that, yeah, it's never too late is definitely important.
I would also like to comment. My name's Dr. Lucky. I'm an obstetrician at White Memorial. I feel like I've met you before. So in our institution, we do have residents in training, and because of myself and Ingrid Suarez, who you met at the conference last time, we do a lot of education on the resident level. And what's interesting, during those conferences, the attending physicians who are usually at the conferences choose not to come. They feel like it's geared just to the residents. We actually did the viewing of Return to Zero with this year's teaching, and we had 2 attendings. But I would recommend, especially in community hospitals where you don't have resident training, try to find someone who's a champion for you, and they could try to encourage some continuing medical education, through medical staff meetings or what have you. That would give more awareness. You encounter lots of different attitudes, and I think a lot of them are to protect the physician from having to deal with going through that grief process. And it's interesting, I worked with a doctor for years who was really detached from patients that lost their babies, and he recently had one that was a young girl, and I guess he was close to this couple, and it affected him really strongly this time. So now he's been more supportive of our efforts. But I think you have to find a champion, because there is a lot of resistance among physicians, and that we don't get training at all, really, in medical school. We got very little training. I didn't get any training in residency, and it's only with the Resolve Through Sharing efforts that we've brought it to the resident training since I've graduated. But that would be my recommendation, finding someone that you feel is supportive and see if they can help you educate and gain awareness.
Hi, I'm Annette from Mother Woman from out east. And what I'm also hearing is that there are certain professions where you have to develop a thick skin in some ways to get your job done. You know, ER docs, the NICU, the ICU, you know, labor and delivery, you know, military people, EMTs, and parents, right? We have to be able to switch on and off from being competent, getting the job done, and yet sometimes that comes at the expense of allowing our hearts to stay open. And so the key to, you know, to moving back and forth, and that's not easy to do, to keep your heart open and at the same time get your job done. And so when we talk to parents, we're always encouraging seek wise counsel, find your tribe, and self-care. And for all of us to remember that in order to keep our hearts open while we're doing the hard work, that we have to take care of ourselves so incredibly well, so that we can walk that fine line between the two.
Yeah, I think that's definitely a good point. I know that, you know, as my career has moved on, you know, I think you hear that, oh, you have to have a thick skin, and you become jaded, and or potentially, you know, more realistic. I think that, you know, you have to consciously make an effort to not let that skin get too thick, and that's sometimes what happens. And you know, you try and not be vulnerable because it hurts to be vulnerable. So I think that you have to make an effort to still be okay with that, and part of that is being able to cope with it when it happens. And so that's what we're talking about.
Thank you so much for your very interesting talk. I wanted to just say a couple of things. I'm Dr. Ronna Limbo with Resolve Through Sharing, and I've been in this field for about 35 years, a little bit over that. And I've come to understand some things about relationships, and that is that I think physicians have often been targeted as a group of people that can be difficult to work with. And my own sense about that is that part of what works in working with physicians, because I've been a bedside nurse for a number of years, so I've worked with physicians in some very difficult circumstances. They need our time and attention at times, and I don't think that they often get that. I think people might be afraid, or they may think that it's inappropriate, but that's a number one thing that I think is sometimes lacking, is the interprofessional team leaves the physician out as somehow not needing to hear, I'm thinking of you, I know this was hard, a pat on the shoulder, and go about your work. But it's acknowledging that you and I have a relationship, and that how you're feeling about this matters. And the second thing is that, well, I guess there are two others. I'll try to be brief. As part of Resolve Through Sharing, we offer a physician talk if the organization where we're giving the training would like it. And we ask a question, has this changed your practice? It's 1 hour. Mm-hmm. And I remember, I'll just give an example of one that I did in a Chicago area hospital. 75% of the people in the room said that their practice was changed from 1 hour of listening to me speak and engaging with me. I think that's pretty astonishing. So it gets back to what you were saying. Education makes a difference, and there's also, thirdly, there's a lot of literature now on teaching empathy, and the work of Solomon and some other folks that have been working in palliative care. There's a lot of good literature in palliative care on education. So I would just recommend, if you're looking for a way of designing education for any group of people, that field has a lot of good work in it.
All right. Thank you. One other thing I would just add, and I think we're running out of time here, but if your hospital or facility where you work doesn't have that type of culture where when there is a loss or an event which is emotional for the staff, if they don't have debriefings and or counseling available, I think I would, you guys can all go back and promote that. It's very important. Every time we have a code event or even a near code event, we're required to have a debriefing where it doesn't necessarily have to be an hour. It can be 5 minutes where you sit down and talk about the event and let people share, try and identify what went well, what didn't go well. Usually it's a fairly positive feedback kind of experience. But then a lot of times if it seems like it's a more significant event, we'll do a follow-up debrief, days or hours or days later, hopefully relatively close to the event, to make sure that everybody's processing appropriately and allow people a forum to sort of express their feelings. So I think that that's an important part of the culture to promote in your hospital and or facility. Thank you.